So good morning, everyone. My name is Ashley Espinoza. As you can also call me Ash for short. My pronouns are she, her, hers, and I'm with the Child Abuse Prevention Center as the Cal OES project manager. On behalf of the Coalition for Victims of Child Abuse, I'd like to warmly welcome you to today's symposium. We're truly grateful that you've chosen to spend your morning with us. We know how full your calendars can be, so we deeply appreciate the work each of you do to support children, youth, young adults, families, and communities impacted by trauma and violence. And today's symposium was intentionally selected based on feedback from our chat subrecipients and advisory committee. Across organizations, we've consistently heard a need for more training and practical guidance around supporting youth in complex and overlapping needs, particularly when trauma, mental health, ADHD, autism, and substance use may all be impacting a young person at once. Because supporting the professionals who do this work is such an important part of our mission, I would also like to briefly share a little bit about who we are. So for those who may be new to our work, the Child Abuse Prevention Center is a statewide organization focused on strengthening families and communities to prevent child abuse and neglect before it happens. This program is funded through the California Governor's Office of Emergency Services, also known as Cal OES. While we are based in Sacramento, our reach extends across California through partnerships with up to 32 organizations statewide. And as part of this work, we provide training, resources, technical assistance to therapists and service providers to strengthen trauma-informed care for children and youth who have experienced abuse or violence. We also support the professionals' growth of providers across California by helping strengthen skills, build confidence, and expand culturally responsive practices to better serve children, youth, and families from diverse communities. So before we get started, I just want to quickly review a few Zoom housekeeping items. First, please be sure to have your microphone muted unless you're speaking. This helps reduce background noise and keeps things clear for everyone. Feel free to use the chat and the QA box throughout our time together. Both will be monitored, so drop any questions or comments in there as they come up. We encourage reflections and engagement, as we'll also reserve time at the end of the session for live Q&A with our speaker. We are also recording today's presentation for internal purposes. We'll be sharing the slides and recording with you all afterwards. And lastly, you're welcome to use a Zoom feature like the raise hand option and any other reactions. So please engage in whatever way feels most comfortable for you. And we also invite you to fully be present during these trainings, as some of the content may resonate with you both professionally and personally. We encourage you to participate at a level that feels appropriate and supportive for you today. So it is truly my pleasure to introduce today's presenter, Shannon Radford. Shannon is an independently licensed clinical social worker with extensive experience providing direct clinical care, supervision, and training to professionals working with youth, adolescents, and young adults impacted by trauma and co-occurring conditions. Her clinical background includes trauma-focused cognitive behavioral therapy and works with individuals experiencing co-occurring mental health and substance use disorders. She brings specialized expertise in trauma-informed, strength-based, and community-engaged approaches to care with a focus on supporting providers serving youth with complex needs. In addition to her professional experience, Shannon also brings lived-in professional experience working with neurodivergent populations, which helps inform her work related to ADHD, autism, and neurodivergence. Through her role with the Institute of Health and Recovery, Shannon has facilitated engaging and practical trainings that emphasize real-world strategies, case scenarios, and peer learning. So with that, we are so grateful to have Shannon with us here today to lead this customized training for our networks. And so Shannon, thank you for being here and for sharing your time and expertise with us. The floor is yours.
Thank you, Ash. I'm excited to be here and navigate Zoom, even though I should know how to do it by now, but
Same here. You're totally fine. Let me just stop sharing my screen if I'm able to. Okay, there we go.
Every time I figure it out, there's an update, and then I have to relearn it all over again. Okay. Okay. Can you see presenter? No, you can just see the slide.
Yes.
Great. Now let me just move the captions over. All right. Well, welcome everyone. Today we are going to be talking about youth co-occurring disorders on ADHD and autism. We are going to be exploring this complex intersection between neurodivergence, trauma, substance use, mental health, and kind of figuring out how we can work with youth who are struggling with these concerns. As Ash said in her wonderful introduction, that was the first time I've had somebody introduce me before. So pretty cool. But anyway, I'm a youth and young adult trauma specialist at the Institute for Health and Recovery, and I'm really passionate about providing trainings regarding trauma-informed care and neurodivergence to providers in Massachusetts who work with folks struggling with substance use. So just quickly, I'm going to plug the Institute for Health and Recovery where I work. So we are a nonprofit organization in Massachusetts. We center substance use, trauma, co-occurring disorders, and lived experience, and we provide both capacity building and direct care services. So unfortunately, probably lots of you are in California, so you can't access our services, but you can still look us up and connect with us online. All right, so Ash already asked you all to start introducing yourselves in the chat. Again, if you haven't and you want to throw your name and pronouns, role, organization, and then if you want to add one thing you are looking forward to. I know one thing that I'm looking forward to is summer. I don't know what the weather is like there, but here it is kind of rainy. It's like 40 degrees. So not super summery feeling. Tracy, looking forward to kids being out of school. Nice. Okay, so y'all can continue to post in the chat, but I'm going to move on to the next slide. So in addition to what Ash already talked about in terms of training expectations, I ask that we all acknowledge our training needs and prioritize self-care. So I know that for me, I oftentimes need to be doing something with my hands, like coloring, if I am participating in a virtual training. So if that's what you need to do, please feel free. I ask that we be curious and respectful, and in conjunction with that, that we be aware of intention, but take care of impact. So when I'm talking about that, what I'm saying is I think that we all have the best intentions when we speak, but sometimes things can come out in a way that is harmful to others. So I ask that we hold each other accountable. And if there's anything that I say or somebody else says that has caused harm, please feel free to bring it up and we can address it in a respectful way, kind of modeling how to do rupture and repair. I also ask us to practice courage. So I'm one of those people in virtual trainings who tends to have their camera off and kind of just be observing. But I find that when I do have my camera on and I challenge myself to raise my hand or speak aloud, I feel good about it after. So I challenge us all to practice courage and to sit in that discomfort a little bit. All right, so training goals. Increase understanding of co-occurring mental health, substance use, trauma-related, and neurodevelopmental conditions in youth and young adults. Then we're going to examine how those things intersect and shape care needs. Then we are going to move on to more practice-based strategies and skills to help you build confidence in working with this population. So just a brief agenda for the day. We're not going to follow this minute by minute, but this is a training on neurodivergence. And in doing that, I'm modeling what can be helpful for folks who are neurodivergent. And having a plan and structure is one of those things. So first, we're going to talk about key terms and concepts. Then we are going to talk about risk and protective factors before we go on a 10-minute break. When we come back, that's when we are going to move more so into the what can I do about it? And we will have time at the end to ask questions. And then there is an evaluation that we have, and there will be a QR code and a link. Okay, so let's just hop right in. So when we are talking about neurodivergence, you could hear the term neurodiversity, or you could hear folks referring to it as a neurodevelopmental disorder. So sometimes folks are referring to the same thing when they use these terms, but they do differ. So neurodiversity and neurodivergence was a term that was coined by somebody who did have autism and was trying to reframe it as not a deficit, but just as a difference. So in using that term, you are acknowledging that neurodivergence is not necessarily a disorder, but you're holding the fact that it's just a difference and there's no right way of thinking, learning, and behaving. In clinical and medical settings, oftentimes we talk about neurodevelopmental disorders. And that specifically refers to diagnoses or conditions present from early development that impact brain growth and functioning. So ADHD and autism are neurodevelopmental disorders, but they can also be referenced and referred to as being neurodiverse or neurodivergent. Okay, so I am going to quickly review two different neurodevelopmental disorders, and then a third, which is actually co-occurring neurodevelopmental disorders. So we'll start with ADHD. So ADHD is a neurodevelopmental condition that affects attention, impulse control, and activity level, among other things. It often involves difficulty with executive functioning. And we are going to be diving a little bit deeper into executive functioning on the next slide. When we're looking at autism or ASD, we're talking about a condition characterized by differences in social communication, sensory processing, and pattern of behavior, interest, or routines. And it may include strengths and focused interests and pattern recognition. So where there can be what some folks would be considered deficits or difficulties, there are also some strengths and specialties that come along with these disorders. So you may have heard the term ADHD. So that is referring to co-occurring ADHD and autism, and that's when a person meets criteria for both. And it often includes a mix of attention and regulation differences, sensory sensitivities, and a need for structure alongside a difficulty maintaining it. So it can present with inconsistencies across settings and tasks. And all three involve differences in executive functioning and regulation and may overlap with trauma and mental health challenges. Okay. So when I'm thinking about executive functioning, I love to think about almost Inside Out. If you all have seen Inside Out, there's the control panel and there's anger and sadness and anxiety. I think in Inside Out 2, I haven't seen that one yet. So that's on my to watch list. But there are a couple different components at work when we're thinking of this control panel. So there are emotions which influence the control panel. They are powerful, but they are not in control. And what is in control essentially are the executive functions. So these skills tell our body what to do, how, when, to what extent, and when to stop. So 8 core executive functions are starting a behavior, the ability to start a behavior, the excuse me, the ability to stop a behavior, the ability to shift from one task to another, the ability to regulate emotions, the ability to remember things as we are learning them, our ability to plan and organize, our ability to monitor what we are doing in the middle of it, and the ability to monitor how we are feeling about what we are doing. So I am somebody who has ADHD, and I first just thought of executive functions as like, oh, it's about planning and organizing and that's it. Like you're just not good at organizing. But when I found out that it encompassed all of these other things, it helped me make sense of a lot of other difficulties and behaviors that I was having. Like, and we all struggle with executive functioning sometimes. It's not just for folks who have diagnosed ADHD or autism, but for folks with ADHD and autism, it can cause severe impairment throughout their lives because it's not just something that happens once, it happens like every single day over and over again. When I think about some of these, like monitor what we are doing in the middle of it and monitor how we are feeling about what we are doing. I think about sometimes I go on social media for like 5 seconds and then all of a sudden it's been 3 hours. And I'm like, why am I doing that? Because I didn't even want to spend my time doing that. So when we're thinking about executive functioning, we're not just thinking about organization, we're also thinking about not being able to really keep track of time or even what we're doing and if we're interested in doing it. So just a note on all executive functioning skills, we are not born with them. We are born with the potential to develop them. So we have a blueprint. but these skills develop over time through experience, practice, and support. Early relationships and environments matter. They shape how these skills develop, and they influence how potential is expressed. So this I was originally going to do a poll, but now I'm just going to have us write it in the chat. So or you can unmute, which of the following do you notice most often in youth with neurodevelopmental differences that you work with? Difficulty getting started, emotional reactions or escalation, trouble focusing or staying on task, avoidance or shutdown, inconsistency, or something else. I'll give us a couple minutes to think and process and respond. Emotional reactions, avoidance or shutdown. Another emotional reactions, escalation, all of the above. Shutdown, trouble focusing or staying on task. This is great. Difficulty getting started, avoidance and shutdown. So we have a lot. I think that every single one of them was referenced. And sometimes we don't realize that folks are experiencing a neurodevelopmental concern when we see these behaviors. We might just think that they are being defiant or difficult, or that it is related to something else, like a mental health disorder. And mental health disorders are different from neurodevelopmental disorders. Thank you, everyone, for responding. If you think of anything else, you can continue to use the chat. And again, if you ever have any questions, I'm going to try to pause here and there so that we have a little bit of space for processing and reflection. But at any point, you can write in the chat, and Ash will keep an eye on it for me and then shout out. All right, so we talked a little bit about neurodivergence. Now we're going to talk a little bit about mental health. And mental health is something that we talk about all the time in our roles. But do we actually talk about what it means? So it's a component of health and wellness that allows us to think, feel, communicate, adapt, and cope. And noticeable changes in mental health that significantly impact a person's functioning can indicate the presence of a mental health disorder. And a mental health disorder is a condition that significantly impacts feeling, mood, thinking, and behaviors. And it impairs multiple domains in a person's life, such as school, work, home, and community. And I forgot I have like a timer on some of these, which is why they're moving faster than I want. But if we go back and we look at what mental health disorders are, you can see a lot of overlap between the executive functioning challenges and the ADHD and autism diagnoses and the functional impairments that are present in mental health disorders. So, what are co-occurring disorders? The presence of one or more mental health, substance use, and/or neurodevelopmental disorder. So that could be ADHD, PTSD, and look at that, it keeps doing it. ADHD, PTSD, anxiety, substance use disorder, any combination of those can be understood as a co-occurring disorder. And some characteristics specific to co-occurring disorders is that there is significant physical, emotional, functional, social, and economic consequences for the person served and their loved ones. Symptoms can vary in presentation and severity over time, and they are bidirectional, which is where we get into the complex intersection, which means that we kind of have the question of like, what came first, the chicken or the egg? Like perhaps somebody experienced early relational trauma and they are exhibiting symptoms of ADHD, but also they were predisposed genetically to have ADHD. So they could have an ADHD diagnosis and then also be influenced by trauma and then perhaps start using substances to manage all of these symptoms. And then we have substance use disorder. But based on where a person is, like if they're going into treatment for a substance use disorder, we may miss those other things because we're just seeing the substance use, which is why it's so important to really remain open and curious and reflective whenever we're meeting with folks. Okay, looking at the prevalence of co-occurring disorders. So for under 18, ADHD, 11.4% of youth have been found to be diagnosed with ADHD, 3.4% with ASD, and 5% with PTSD. And looking at these comorbidities, which is sometimes used instead of co-occurring, we have PTSD, substance use disorder, oppositional defiant disorder, anxiety disorders, and autism that overlap most with ADHD. With ASD, which is autism, we have, again, ADHD, intellectual and learning disabilities, and epilepsy. When we're looking at PTSD overlaps most with anxiety disorders, depressive disorders, and substance use disorders. So keep that in mind, but also recognize that a lot of these statistics don't necessarily represent everybody's experience. And I want us to be cognizant of the fact that folks may struggle with a lot of these things, but not have a diagnosis. And that doesn't mean that they are any less valid because they don't have a diagnosis. All right. Before we move on to trauma, does anybody have any questions about neurodevelopmental disorders, mental health disorders, what the difference is? I'm going to assume that's a no. Okay. So what is trauma? I'm sure if y'all have been coming to these trainings previously, you've heard a lot about trauma already. And it's also defined in multiple different ways. So this is a lot of words on a slide, which I don't normally do, but I'm going to read it and then I am going to pick out very specific parts. So individual trauma results from an event, a series of events, or a set of circumstances that is experienced by an individual as physically or emotionally harmful, and there's that timer again, or life-threatening, and that has lasting adverse effects on the individual's functioning and mental, physical, social, emotional, or spiritual well-being. So what I want to pick out of this definition is the 3 E's. So event, experience of the event, and the effects of that event. So these 3 things are highlighted because not everybody experiences the same thing as traumatic. So somebody could be in a car accident, but they don't experience it as traumatic. So for them, it's not trauma. Somebody else could be in a car accident, experience it as traumatic, and then have lasting emotional and behavioral effects. And for them, that is trauma. So I don't like to necessarily go through a list of like what is trauma and what isn't trauma because it is so individualized. And I don't want to, I guess, what is the word? I don't want to dismiss folks' experiences. So even if they are bringing something to me that they identify as traumatic and I don't, it doesn't matter what I think. It matters how the event is impacting them and then the effects that it is having. Okay. So I'm going to talk briefly about the hand model of the brain. There are a couple things I talk about in every single one of my trainings, and one is the hand model, and the other is the window of tolerance. So I'm going to go ahead and try to, sometimes with this background, it's hard to see. But in this model, which was created by Dr. Dan Siegel, a child psychiatrist, this is our brain when we are fully regulated, when we are within our window of tolerance. And when we are within our window of tolerance, we are able to get up, engage in activities of daily living. We're able to go to work. We're able to come to trainings and focus on trainings. We are able to use our coping skills. It doesn't mean that we don't get upset, but it means that we are able to access our coping skills when we do get upset. So now I'm going to open up our brain here. So down here, this is our brainstem. This is the part of our brain that develops first. And right here we have our limbic system. So both of those things together, you can refer to as the downstairs brain or the lower part of the brain. And these parts of our brain are in charge of the fight, flight, freeze response. So then up here, I'm going to go ahead and close this again. This is our cerebral cortex and then our prefrontal cortex. This is where all of our executive functioning skills live, right up here. So down here, survival, up here is logic and reasoning. So again, when we're regulated and doing good, we look like this. And we may be encountered with triggers, but we're able to explain them. Like sometimes I use as an example, I have 3 cats. So one time actually during one of the trainings where I was explaining this, my cat knocked over the water fountain that they have. And for a second, it's almost like my lid was going to flip. I almost activated a survival response. But then I was like, wait, okay, I know that I'm safe and that that was just a water fountain being knocked over. But that is because I have done a lot of work to keep my brain in this area, to extend my window of tolerance so that when those things do happen, I don't flip my lid and completely lose access, to all of my coping skills. So what happens when a youth we work with has experienced trauma is that they could be exposed to a trigger which could be as small as, I've seen it like a clinician wearing a certain scent. So the child does not even understand what it is they're being triggered by. But what we see then is an emotional outburst that is completely out of proportion to the situation. So it could just seem like it's coming out of nowhere. Because what is happening in that moment is that the kiddo is smelling that perfume or cologne or whatever it is that they associate with a perpetrator, and they are flipping their lid. So they are right here in that survival zone. And that survival zone, that survival space, that helps when we are in a life-threatening situation. But when we are responding that way and it is because of somebody's cologne, it is not helpful and can actually be harmful. But we as the adults in this situation are not able to just use our words to tell this kiddo that it's like, we've gone over coping skills and like, I don't understand why you're not using them. Just breathe. Because up here, this is where all of that logic, reasoning, comprehension lives. And when they flipped their lid, they do not have access to those skills. And I like this model because you can see very visually that they are not connected. So it's not that folks are not trying, it's that they are not able to access those skills in those moments. Does anybody have any questions about this? Could be review for some folks. All right, great. So now I'm going to move from that straight into our window of tolerance. So again, I use the term window of tolerance when I was doing the hand model, which is why I like to do these one right after another. So this is our window of tolerance. When we are in our window of tolerance, our reactions adapt to fit our situation. Our feelings are tolerable. We are able to experience empathy, remain open and curious. We're able to use our cognitive coping, which is kind of like reality testing, which is our ability to use like cognitive behavioral therapy to acknowledge that, like, oh, wait, this isn't actually a situation in which I need to be feeling this way. Something else could be happening. But again, we're able to do that only when we're in our window of tolerance. We also feel safe and we're able to engage in social relationships. All right. Then when we do flip our lid, we go into either hyper or hypoarousal. So when we're thinking about stress responses like fight, flight, or freeze, hyperarousal is where fight and flight live. So I like to think of hyperarousal as feeling dysregulated with a lot of energy, and hypoarousal as dysregulated with little energy. So when we're seeing hyperarousal, we're seeing more of those emotional outbursts, emotional reactivity, impulsivity, racing thoughts, hypervigilance. But hypoarousal, we actually may not notice as much, especially if we are in settings where we are working with like 30 kids and there's only one of us, then the kids who are exhibiting hyperarousal symptoms or characteristics are probably going to get our attention more so than the kids who are going into a hypoarousal response, because that can look like reduced movement, dissociation, and feeling emotionally numb. So neurodivergent youth and youth who have experienced trauma may move in and out of this window more quickly and more often than other youth.
I wanted to interrupt real quick, but
Yeah,
Kimber
sure.
had a question in chat. What is a youth is exhibiting these behaviors but have not diagnosed? What do you suggest or say?
Yeah, so in terms of, it really has to do with the specific situation. Sometimes diagnoses are not necessary in order for us to cater interventions to that specific uh, symptom or presentation. What we can do, if it is like trauma that we're noticing, is that we can then provide some psychoeducation. Like I have actually done window of tolerance groups and used the hand model when I am working with youth and young adults and teenagers. And they are able to access that information and make sense of it. And I also explain it to the parents. And then that helps us gauge interactions and what to do next. But if it is a neurodevelopmental disorder, sometimes in those cases, it is helpful to have a diagnosis because it can help folks get accommodations in certain settings. So whether that is in elementary school or even later on in life. Like when I was in graduate school, it was helpful to have like an official ADHD diagnosis because I could go to the Office of Disability Services and get specific accommodations that allowed for extensions, um, and something else that I can't remember. But in certain cases, it is helpful to have a diagnosis. Sometimes people really want to have a diagnosis. Sometimes youth will even come to you being like, I'm pretty sure I have this because it's helpful to put things into a box. But again, like if a diagnosis isn't really going to support access to resources, it's not necessarily necessary, and you can just focus on the treatment and psychoeducation and figuring out what you can do to best support that youth. Does that help, Kembra? Yes? Okay, great. Thank you for asking. Sometimes it's hard to put these concepts into practice unless you're thinking of like a particular case or example. So please feel free to bring your own experiences into this throughout the training because I want it to be as helpful and applicable to you as possible. All right. So here is an image that is just looking at some of these differences and how they overlap. So we have neurodivergence, mental health, trauma, and substance use. So some overlap we see between neurodivergent symptoms or characteristics and mental health conditions are emotion regulation challenges, executive functioning differences, and social connection difficulties. When we're looking at neurodivergence and trauma, we see some overlap with sensory sensitivities, overwhelm, and shutdown. Also, emotion regulation, too. When we're looking at trauma and substance use, we're looking at coping and self regulation challenges and the impact on brain development and function. And then when we're looking at the overlap between mental health and substance use, we look at again, like this is kind of the what came first. Like perhaps somebody was using substances and then it led to impairments in mental health. But I tend to come from the opinion that somebody used substances and then continued to use substances, perhaps based on trauma or their own experience, which I am going to talk about a little bit next. But again, once folks start using substances, that can lead to mental health challenges. But people often use substances because they're struggling with their mental health or trauma. So again, it's also interconnected. And the difficulty with that is that they can intensify challenges and impact daily functioning even more so than just one. Also, I can say that very rarely do you see just one of these. Oftentimes, there's more than one thing going on, even if we don't see it at first. Okay. So what I like to emphasize is that, like, while it can be helpful for us to conceptualize these behaviors through multiple lenses, it is not necessary to determine causality to support individuals in decreasing and managing symptoms. And it's also not something we're probably going to figure out right away when we do the assessment. We are going to learn some of these things over time as we work with clients and get to know them better. And that's okay. It's okay to adjust our understanding as we get more information. All right, so let's move on to risk and protective factors. So when I'm talking about risk and protective factors, I like to talk about substance use. So why might a neurodivergent youth use substances? Given what we know about executive functioning and the window of tolerance, Terrence, to regulate. Yes. Anybody else? Trying to manage feelings, to self-medicate, fit in, cope, feel better, provide dopamine. This is great. Help with socializing. Yes, that is a good one. That is also like very specific to neurodivergence. Not knowing what else to do. Yeah. Folks wouldn't use substances if they didn't work. I always like to say that. So, um, that was great. Thank you all for to stop overstimulation. Yep. To get back into our window of tolerance. If you think of anything else, you can continue to put it in the chat. I'm going to go ahead and move on to the next slide. So when thinking about risk and protective factors, thinking about why substance use may play a role or other potentially risky behaviors, I think about the brain's neural networks of reward. And also with all of these concepts, you can get a lot more complicated with them if you would like, but I find that knowledge is a great way to support not just providers, but individuals struggling with these things in being empowered. And again, empowering folks, I'm pretty sure I just said that empowering is empowering, but empowering folks helps combat the disempowerment that comes with trauma and neurodivergence. So I really believe that learning these things and having them be accessible to the people we're working with can be a super helpful tool. So again, there are a lot of, different chemicals that could be in that circle besides just reward centers of the brain, but we're just going to talk about reward centers of the brain for this purpose. So each one of us, needs a certain amount of pleasure and reward to feel regulated every single day. So we can fill that need with things like substance use, relief of physiological distress. And what that means is that, like if you're really thirsty and you drink water, you're like, wow, that was great. Like, I don't normally like water, but if I'm really thirsty, it gives me a sense of pleasure and reward. So that's what I'm talking about when I say like relief of physiological distress is meeting one of those needs. We also have behavior consistent with your value or belief system. That could be a hobby, it could be going to church, it could be spending time in community. We also have physical activity, positive relational interaction, music and rhythmic sensory input, sweet, salty, fatty foods, and also the sensation of cutting, picking, and pulling. So all of these things stimulate the reward centers of our brain and lead to a sensation of pleasure and safety. So I am going to take that and then imagine that all of our reward goes into a bucket. So we need to fill our reward bucket every day to stay regulated, to stay within our window of tolerance. So I'm going to talk about this and kind of exhibit it a little bit more with an example. Okay. So in this example, we're going to talk about Cleo. So Cleo is a 16-year-old female identifying individual who lives in a two-parent household, does not have to worry about access to food, has all of her basic needs met. In this daily contact map, let me see if I can annotate. I know I can, I just have to do it. Okay, so this inner circle here, this is looking at interactions with folks in Cleo's innermost circle. So her family, the folks that she lives with. And then right here, the second circle is like the next ring. So that's looking at like interactions with friends. And then this third circle is interactions with acquaintances. So maybe like teachers at school. And then this is also, let me clear that. So with this daily contact map, we're starting at 6 a.m. and then we're going to 12 a.m. and we're just going to look a little bit at the relational interactions that Cleo has throughout the day. Starting at 6 a.m., perhaps Cleo wakes up and has a pretty good relationship with mom. So comes down, says like, hey, mom, off to school. Maybe sees brother and has a positive relational interaction. So already starting off the day pretty well. Then her friend picks her up from home to drive her to school. So then she's already getting some of that positive relational interaction. And she hasn't even gotten to school yet. Then we're at school and she has positive relationships with the teachers. So she checks in with her homeroom teacher, just a quick thing. And we move on throughout the day. We're looking at, again, interactions with friends, teachers, and then Cleo also engages in after school activities. So not only is she getting those positive relational interactions, but she's also getting physical activity and music and rhythmic sensory input. So by the time Cleo gets home, she's got her reward bucket almost entirely filled up. Let's go ahead to the next. Oh, I got to close the annotate thing. All right. So there we see the positive relational interactions, which is meeting like the baseline need. And then rhythm, physical activity because of the after school sports. And then, you know what, maybe Cleo's like, I think I would really like some ice cream. And since ice cream could be the last thing to fill up Cleo's bucket. So that's looking at, again, what filling a reward bucket could look like for a teen and how their relational interactions throughout the day and their activities can influence the way they fill their reward bucket. So in contrast, we're going to take a look at Jules. So Jules is the same age, but Jules is new to the school, comes from a single parent household, and needs to work after school in order to support mom in paying the bills. She has a really great relationship with mom and with teachers, but she doesn't have any friends yet because she is new to the area. So when we are looking at Jules' day, Jules starts the day with some positive relational interactions with her mom. We don't see anything in this middle circle here. But then we look at the outer circle. So we see that she's interacting with her teachers throughout the day. And then maybe mom picks her up from school, brings her to work. And then she's interacting with people from work, which is where we see that other arrow right there. And then gets home, says goodnight to mom. So when we're thinking about ways that Jules is going to fill up her reward bucket, positive relational interactions is way lower than Cleo's.
No, it's okay.
And then perhaps Jules goes to a party and tries alcohol and is like, oh my gosh, this is great. I think I want to keep doing this. And Jules is going to go back to alcohol more than Cleo. who has all of these other ways to fill her reward bucket. So when we think about why two youth may go to the same party and try substance, and one might continue to go back to that substance and one might not, it usually has to do with all of these other factors, which then also looks at, social determinants of health and resources and identity and all of those things. So also, when we're thinking about neurodivergence and substance use, impulse control is an executive functioning skill. And so there's often not that pause in between the wanting to do something and then the action. Okay. Oops. Sorry, Heather. I'm just seeing your comment now. Did the question get answered, or do you want me to show you again? The smallest circle in the middle was closest relationships, and then the second circle was like friend relationships, and the last circle was acquaintance relationships. So it kind of starts with closest and then moves outward. Got it. Okay, great. So before we go on break, I just want us to take a moment and think about how you all fill your reward bucket daily. What's one or two things that you do? Because we all do it, even if we're not thinking about it. And I can go back to, I'll go back to the slide that shows. What activates our brain's neural networks of reward. Sweet treat. Go to the gym, Zumba, coffee, Tai Chi. This is great. Coffee with sugar, Pilates, walking outside, reading and baking, play with pets, go on walks, vacation, walking in nature. Yes, socialize, crossword puzzle, podcast, playing with kids, dance breaks, vacation, be around animals. Yes, I forgot to say positive relational interactions is not just with people, it can be with animals too, which is actually more helpful for a lot of folks who have experienced trauma if the trauma happened in relationship with other people. All right. Well, thank you everyone for sharing those. Let's see, I'm going to stop sharing my slides for a second and let's see. Here it is. I tried to do the math of what time it is there versus what time it is here. But here it is 2:01. I'm assuming it is not 2:01 there. So, all right, 11:01 here. So why don't y'all come back in about 10 minutes and then we're going to jump into some practical strategies. So 2:11, no, sorry, 11:11.
I'll put a timer up.
Okay, great. Thanks, Ash. Oops, now I'm unmuted. There we go. All right, I hope everyone is feeling refreshed from their little break. Um, 2 hours doesn't seem like a long time, but sometimes you can start to lose focus a little bit around the like hour and a half mark. So I find usually inserting a break a little bit before that is helpful. All right, so let's move into what we can do. And first, I want us to start off with oops, nope, I don't want to go there. I want us to start off with a group discussion. So, what are some strategies you utilize to help establish rapport with clients in your first meeting? An established rapport means establish a relationship, essentially. Like, how do you start building trust with folks? And then I'm curious if the strategies you use differ when you are working with a neurodivergent youth, and if so, how? So this might take a couple minutes of thinking. So I'll give us a minute or two, and you can either unmute or throw it in the chat. Chat with them about their interests. Great. Thanks, Rachel. Get on their level physically. Yep. Play a game with them, let them choose which game, and casually chat with them about interests, things they like to do. Building trust by letting them know they are in a safe space. Ask about their favorite activities. Try to meet their preferences, let them explore the room, similarities and experiences, and try to encourage more talking about their experiences and add my perspective with enthusiasm and excitement. Create a comfortable environment. These youth are lucky to have all of you. Y'all are doing such a great job already. I have a bunch of sensory tools and fidget tools on hand they can use while we chat, which I've noticed helps them open up. Yes, I love that. Be friendly, calm, and respectful. Listen well and use simple words. Yes. And we're going to talk a little bit about how we communicate too, because using simple words is great. And then also we have to make sure we're not using a tone not that is like, oh, you're a baby and you don't understand, but an accessible way to say things. Uh, Praise them, provide affirming statements like that's a really cool hat. It looks great on you. You have good fashion sense. Do not judge. I want them to feel respected. Yes, non-judgment is really super simple. And respect communication styles. Yeah, that's great. So it sounds like you all already do a lot of trauma-informed engagement strategies that would work with folks who are neurodiverse. Are there any other special accommodations y'all use when you know you're working with somebody who struggles with executive functioning? Allow movement, express that inner child, fidgets and arm's reach. Have them color or do art and other creative projects. Provide a snack basket to break the ice. Asking caregiver. Oh yeah, asking caregiver for tips is great too. Knowing what's helpful and not helpful while they're going before they come into the room. Read their nonverbal cues. Be mindful of the space too, not overloading their senses. Yes, lighting in the room. Sean and Mary, it's like you talked before you did your chats because they're right in conjunction with each other. Relax, calm music. Ask open questions and give time to talk. Coloring pages available with color pencils. I love this. Yes. So we're thinking a lot about the space, and we're also thinking a lot about the way that we are showing up, which influences the space. I know that when I was doing direct care, I did not use the overhead fluorescent lights. I brought in a couple of my own lamps. Oh yeah, beanbag. That's great. Um, Sometimes I know one of you said that you like physically meet folks at their level. I like to sit on the floor just in general. So oftentimes when I was working with youth, I'd sit with them on the floor. Again, not if the youth was really escalated. That's not a great idea because then you're putting yourself right in reach if they decide to throw out a punch or throw something when they are feeling really dysregulated once they flipped their lid. But if you are having like a calm relational interaction, then sitting on the floor and again, just being in relationship is great. And also paying attention to things like eye contact, um, and not taking it personal if you're like, oh, I feel like this person isn't listening to me because they're not looking at me, because they could be listening. I actually I do that all the time. I did it to an extent that when I was running a partial program with adolescents, they would tell the new kids, they'd be like, just so you know, Shannon is listening, but she doesn't always look at you when she's talking. And kids are okay with that, and they actually prefer that you show up as your authentic self. So it's okay to model. Also, like if you are a neurodivergent adult, it's okay to model how you engage in the world and how you're able to create accommodations for yourself. So that's, I think, one of the most important things when working with all youth, but especially when working with neurodiverse youth and folks who have experienced trauma. They are very sensitive to adults' feelings and moods, which brings us to our next slide. So again, because of development, past experiences, and power dynamics, the way that we show up is oftentimes, it's important no matter what, but it can throw off a kiddo who has experienced trauma or who is neurodivergent much quicker. Like it could cause them to flip their lid, even if we do something that they perceive as dismissing or rejecting, because it happens a whole lot quicker. Let's see. Mary has a comment. Sometimes I have to educate the parent about that point you just made also. Yes, especially when we're working with youth and young adults, educating the parents, caregivers, teachers, anybody that the youth is interacting with on a fairly regular basis is important to talk to them about it, because it's great that we're able to apply all of these strategies once a week or twice a week, or I don't know, like a couple times a week, however often you see your kids for a couple hours. But if they are not receiving the same type of care in their environments, it's going to be tough for them to continue working on healing and coping. So thinking specifically about how we communicate. And also what happens if we start to notice that a youth we are working with is kind of almost starting to move outside their window of tolerance. Because in that point too, they're not really able to process, as we talked about with the hand model. When you're here, you can't access language or process language. So our words are not going to be helpful. But how we show up is helpful in preventing de-escalation, and then also, no, sorry, not de-escalation. That's what we do after. But it is helpful in preventing escalation and also helps with de-escalation if needed. So thinking about tone, which is how your voice sounds, calm, steady, not urgent, not too loud or sharp. Pace, which is how fast you speak and respond. So you don't want to be slow. Again, when we're thinking about kind of like a Goldilocks situation here, when we're thinking about like, oh, this bed is too hard and this bed is too soft and this one is perfect, because if you are too slow, then it's like, okay, they think that I'm stupid. So again, it's kind of a mix between being like, okay, I'm providing a calm, regulating environment, but I'm not also making them feel like they're an infant. Also, leaving a little bit of space between words or questions, because it does take neurodiverse folks sometimes a little bit longer to process. Like, even when I'm in training, sometimes somebody will ask a question. Um, the facilitator will ask a question, and I'll have a response, but I don't usually have the response until we're on to the next slide. So then it's like, oh, I didn't get a chance to say it, and it maybe looks like I'm not engaging, but I wanted to. So being conscious of how much time we're leaving in between questions and expecting an answer. We also want to think about our body language. So how our body is positioned. We talked a little bit about that when we were talking about physically meeting folks where they are at. But we want to have an open posture, so not crossed or looming. Again, we want to give appropriate space. Sometimes we have to educate the youth that we work with about space. Uh, Sometimes I've noticed, specifically when I've worked with kiddos who had an autism diagnosis, they struggle to conceptualize what appropriate personal space is. So I'd have to talk about, like, oh, let's pretend that there's like a hula hoop around me. And we each have our own hula hoop, and you can't step out of your hula hoop. You could actually get hula hoops and really practice it. But I think it's important too to always remember that we are modeling, and that's one of the most important things that we do in this role. So we want to model how we hope they engage in the world. Okay. So connection before correction. So this is a framework that I use when I am talking about avoiding situations that could be escalating for folks, or again, in recovering from situations in which an individual has flipped their lid. So you want to notice what's happening, reflect back what you're hearing or seeing, validate and connect, create space, and then offer choice. I imagine that a lot of you do this already, but sometimes it's helpful to see it actually like written out in a model, because I find a lot of folks who come to my trainings are like, I don't know anything about this. And then I'm like, actually, you do. And you're doing a lot of the things already, but sometimes it doesn't feel like it because you're like, I didn't see this in a book. So I don't know. It's not what I learned in school. But let's talk about some examples of supportive language. So notice, reflect, and validate. So I'm noticing a shift in your body language. Something feels different than it did a few minutes ago. And then validate, so acknowledge the feeling. That makes sense, especially after what just happened. I can see why that would feel like a lot. Then creating space, so slowing things down and reducing pressure. We don't have to figure this out right now. Let's take a moment. And then close by offering choice. So would it help to step into a quieter space or stay here? Do you want some space or do you want me to stay here with you? Particularly in these moments, it can be unhelpful actually to use just strictly open-ended questions, because if somebody's starting to feel dysregulated, having all of that space might feel overwhelming. But if you're providing them with a couple of options, they still get a choice and have some control, but also don't feel the pressure or overwhelm of having to figure out how to regulate themselves. So saying like, oh, I'm noticing that this is happening. So you're labeling what's happening for them. You're acknowledging and validating that, it's understandable that you feel that way. And then it's trying to reduce that sense of urgency and providing choice again until folks get a little bit back into their window and you're able to move on. All right. So in talking about treatment modalities, I'm going to spend some time talking about recovery strategies. And when I'm talking about recovery, I'm not talking about substance use specific recovery. I'm talking about recovery from, mental health issues, from trauma, can be from substance use. And you don't really recover, so to speak, from a neurodevelopmental disorder, but you do learn how to adapt to a certain extent. And then also try to figure out, like, I feel like I shouldn't have to adapt in this situation, and that maybe I just exist differently. But when we're looking at trauma specific versus trauma informed, every single interaction that we have with folks can be trauma informed, and ideally we're working towards them being trauma informed. So that means that you are focusing on the present, strengths, establishing safety, finding balance, developing coping skills, and fostering healthy relationships. So this can be folks who are considered professionals, non-professionals. Anybody can provide trauma-informed care. Trauma-informed sometimes gets confused with trauma-specific. So trauma-specific includes modalities like TFCBT, EMDR, some specific like exposure therapies. And trauma-specific modalities should only be utilized by folks who are trained in that modality. So all trauma-specific modalities are trauma-informed, but not all trauma-informed practices are trauma-specific. So when we're working with folks who are neurodiverse or experiencing co-occurring mental health, substance use, neurodivergence, we want to make sure that all of our interventions are trauma-informed. Okay. I'm going to talk a little bit about pillars of traditional healing versus our current trauma treatment best practices, because I think this can help us conceptualize a lot of the interventions that are more helpful for neurodiverse folks, because they're not talked about as much. So when we're thinking about pillars of traditional healing, we're thinking about our ancestors, and our ancestors experienced trauma, but they didn't necessarily have trauma therapy or individual therapy or group therapy or any of these things that we're able to provide now, but they still were able to heal and survive. So connection to the clan and the natural world is one of those pillars, which now a best practice is fostering connection through healthy relational interactions, which we talked about. Going back to pillars of traditional healing, we have regulating rhythm through dance, drumming, and song, which is working with the body to regulate the mind. Those are called bottom-up interventions, which we're going to talk about on the next slide, because bottom-up interventions can be especially helpful for folks who are neurodivergent. So a set of beliefs, values, and stories that brought meaning to even senseless random trauma, which is almost working with the body to regulate the, sorry, working with the mind to regulate the body. So top-down approaches. And natural hallucinogens or other plant-derived substances used to facilitate healing with the guidance of a healer or elder, which today is translated as psychopharmacology. I think that when we think of trauma treatment and therapeutic treatment and interventions in today's society, what we think a lot about are the psychopharmacology components and the top-down approaches, which are the CBT, the TFCBT, the more manualized treatment methods that we provide. But specifically for folks who are neurodiverse or who are in the early stages of their trauma recovery, psychopharmacology can be helpful, but sometimes it's hard to start working with the mind to regulate the body because they don't have access to those executive functioning skills all of the time. So you kind of have to work with the body to regulate the mind, really focus on community and support, and then maybe start doing some of those top-down interventions. All right. So here's some examples. And when I'm talking about, again, top down versus bottom up, we go back to that hand model. And so top down, they're speaking to this executive functioning part of our brain. So they are accessible when we are regulated. But if we are not in our window of tolerance, we are not going to be able to access those interventions. So cognitive behavioral therapy, cognitive processing therapy, psychodynamic psychotherapy, I mean, certain components of psychodynamic psychotherapy can be used with bottom up, but things that really require a lot of verbal processing and reflecting could be difficult for an individual who is struggling to just regulate their body and to be in the room. Okay. And bottom up again is starting with the brainstem here. So we're regulating the body so that we're able to then access some of these cognitive interventions up here. Now I'm going to give some examples of what that could look like. All right. So self-regulation, cognitive coping, and actually mindfulness, you need to be within your window of tolerance to access a lot of those things. There are components of self-regulation and mindfulness that are bottom-up approaches, but the cognitive component puts the overall intervention in the window of tolerance range. So does anybody know what self-regulation means? If you were to define it, anybody want to do it, or are you going to make me do it? Relaxing self. Anybody else? Feeling grounded. Managing emotions. Ability to take yourself out of a hyper emotional state, coming back to a calm self after being dysregulated, ability to modulate own feelings and thoughts, being in the window of tolerance, resisting the urge. Yes, so these are all aspects of it. But you know what I learned actually in doing all of this work is that it's not just that. Self-regulation is adapting our energy level to the situation. So sometimes it actually is ramping up our energy. So if we're going to go play a soccer game, we need to have some energy. It's not going to be helpful for us to be like, oh, you know what, I'm feeling really calm and regulated. We need a little bit of that hyperarousal energy to engage in that activity. But if we're going to sleep, it's not going to be helpful to have all of that energy. So self-regulation is bringing your body and your regulation to the moment that you're in. So it can be ramping up energy or ramping down energy, which is why you have to be within your window of tolerance to do it, because you have to be able to kind of recognize where you are and use some cognitive coping to be like, okay, like I'm going to engage in this way because I'm in this setting. So it does require some cognitive thought. But some of the things that you did talk about are bottom up approaches. So primarily grounding and self-soothing, emotional regulation skills. Yes. Okay. So now we're going to talk a little bit about some of these interventions that I have put up here. So mindfulness is something that we talk about a lot, and I think can be thought of as kind of a grounding or body-based approach, but we need to be, I'm going to use the word mindful here when I'm talking about mindfulness, but we need to be mindful of the way that we are using it, especially with neurodiverse folks or with folks who have experienced a lot of trauma. So mindfulness means paying attention in a particular way on purpose in the present moment and non-judgmentally. So let's look at some of the benefits and the risks of mindfulness. So benefits, it enhances present moment awareness, increases self-compassion, and over time, it enhances the ability to self-regulate because it really is helping you kind of realize, okay, where am I in this moment? And what is the appropriate energy level and presentation? Some risks, though, which you need to be especially mindful of when you're working with folks who have experienced trauma or neurodivergence, is that it creates space for thoughts, images, memories, and physical sensations that could relate to a traumatic event, or if it's somebody who is just neurodivergent, it could provide more space for them to kind of cycle about certain things. It can also aggravate and intense symptoms of traumatic stress and leads to re-traumatization. So we do want to be really cautious when we are using mindfulness, components of mindfulness, specifically mindfulness meditation, because that's the one that provides a lot of space. But then we can look at grounding. So grounding can be a component of mindfulness, which is a bottom-up approach. So grounding is a way to detach from emotional pain by focusing attention on the external world. It anchors you to the present, and it can be used when you are overwhelmed with emotional pain and need to take a break so that you can gain control over your feelings and stay safe. So when thinking about grounding, we're not thinking about it as paying attention to your internal experience. Again, it's paying attention to the external world. So an example of grounding, which we can even practice right now, is think about all, I'm trying to think of something that everybody will know, because somebody used an example once where it was like, think of all of the different types of cars. And I was like, I have no idea. So but why don't we take a moment and just try to list in your head um, all the different types of birds that you know or can think of. So, like, that's an example of grounding because it's bringing you out of your internal experience and kind of making you think a little bit more about, oh, wait, like, I'm not actually in here. I'm not actually in danger. I can listen. Let's see, listening to music. Yes, listening to music could help too. Yep, name 5 things you see, 4 things you hear. All of these are great examples of grounding, and there are different types of grounding too. Notice sounds that are close or far away. And I do have a grounding sheet that I am going to provide you as a handout. And you'll get that from Ash with your slides. So it has all of these things that you all are talking about and then more. Because again, there are different types of grounding too. Yeah, notice sounds that are close or far away. Literally lay down and feel your body touch the ground. Yes, notice the colors in the room and focus on your body. Yes, think about like how does my arm feel against the carpet, or like how does the carpet feel, or how does the cold hard ground outside feel, or all of those things help ground us. Okay. So one other thing that I'm going to talk about here is sensory self-soothing, which is another really fantastic intervention that you can utilize with folks who are both neurodiverse and folks who have experienced significant trauma. So when we are thinking about sensory self-soothing, we're thinking about receptors that are located throughout the body that take information from the environment to make sense of and interact with the world. So we talked about a lot of ways that we could make our rooms and spaces feel safe and not overstimulating for folks when we're talking about like lighting, calm music, access to fidgets. This is all thinking about things like sensory self-soothing. So learning about our sensory systems and needs helps us regulate. Let's see. Is cricketing part of the sensory self-soothing white noise? You know what, Michelle? I'm not actually sure what cricketing is. Is it people making noises? I'm learning something new today. Oh, okay. When someone rubs their feet together. I believe that's what people call it. Yeah, so that's kind of like a patterned repetitive movement that is regulating. Um, so I'm going to look at the different senses we have here quickly. So we have visual, auditory, smell, taste, touch. We have our vestibular sense, which is our sense of like where we are in space and time, and proprioception, which has more to do with our perception of like, I often think of like running when I'm thinking of proprioceptive input, or like weighted blankets, things that provide some deep pressure. So, what we're thinking about actually when we're working with a lot of folks who struggle with not, they may not struggle with neurodivergence, but who are neurodivergent and are trying to exist in the world as it currently is, helping them be cognizant of different things in different areas that help them feel regulated can help them exist in spaces that may be difficult to exist in. Um, so thinking of visual stimuli, why don't you all think about what is something visually that you find calming or regulating? Fish tank. Yep. Ocean waves, the ocean. My cat. Fresh air. Happy plants. This is great. And I'm thinking about the ocean too, and the sunset. I'm thinking about like the sunset over the ocean, and that meets a lot of different sensory needs. So the sound of the ocean, maybe like feeling the sand underneath your feet, looking at the sunset. Sometimes there's even a taste to the air, like kind of like a salty taste. All of these things could be considered sensory self-soothing. Or some folks who are neurodiverse could find that really overstimulating. Like some folks really struggle with sand, um, or again, like the feeling of the sand and the sound of the waves. And so I think that's why it's also super important to work with our youth in learning what is regulating for them, but then also what is dysregulating for them. So some things make us more alert and some things make us feel more calm and relaxed. And also, alert isn't necessarily being dysregulated. So it can be helpful to notice, okay, like, if I'm wanting to pay attention in this setting, I know when we're thinking about scents, I feel like I remember that like citrus scents are more activating, and then scents like lavender are more calming and soothing. So thinking about all of those things in advance, and I have a sensory self-soothing checklist that I'm actually going to share with all of you too. It can be a resource for you, or it can be a resource to do with the kiddos or youth that you're working with. Similar to when you do a safety plan with folks, it's looking at, okay, so what will be helpful in the moment? And again, how can we cater your surroundings to what is helpful in regulating, or like what can you bring into the space to help you feel regulated? Okay. And now I want to make sure that we have time for questions. So I'm going to go ahead and stop sharing for a moment. Okay. And I know that was all a lot for 2 hours. I feel like every single one of these topics I could do an entire day's training on. So please let me know if you have any questions or comments.
Feel free to unmute as well, if that's
Yeah,
easy.
feel free to unmute. Or if you're curious about more resources, I could dig them up and send them to Ash along with the handouts I've already got planned. Maybe I just did such an amazing job of explaining everything that nobody has any questions.
I think I see someone with a hand up, or
Oh,
I think it's a clap. Never mind.
oh, everybody's just clapping for me.
Oh, we have a question in chat. I'm curious about
Oh,
supporting neurodivergent parents and
parents. Yes,
parenting children who are neurodivergent.
that's great. So, particularly when thinking about the age group of neurodiverse individuals, a lot of times they didn't grow up, or I'm thinking about me particularly. Like, I didn't know that I was neurodivergent until later in life. And then I was like, oh my gosh, so many more things make sense. But also, then I didn't have the tools when I was growing up. So I didn't know how to share those with younger people. But one thing that I have found particularly helpful when trying to explain neurodivergence to either neurodivergent parents or folks or parents who are not neurodivergent is spoon theory. Has anybody heard of spoon theory before? Some of us, yes, some of us no. So I will also include a copy of that. But what it is, it was created by a woman who had a diagnosis of lupus, and she was trying to explain to her friend what it was like to live with a chronic illness. And so they were at a diner at the time, and she grabbed like a whole bunch of spoons, and she said, okay, so imagine that everybody starts with a certain amount of spoons every single day. When you have a chronic illness, you have to think very specifically about how you are going to use those spoons. Because for me, it could be that it takes me 3 spoons just to get up and get out of bed, where maybe for you, it just takes 1 spoon. So trying to explain, or I found explaining neurodivergence and capacity in that way can be really helpful for folks who have internalized bias against a lot of the behaviors associated with neurodivergence, specifically like laziness. Because if I firmly believe that if people could do better, they would. I don't think that it's enjoyable for anybody to be in situations where it's like, I can't do what I need to do, or it's even uncomfortable to ask for help in a lot of these situations. But I would use spoon theory as a resource. Um, Also, I guess it depends on if the adult is, again, like cognizant of the fact that they're neurodivergent, or if they are just realizing that, like, oh, my kid is neurodivergent. I've struggled with all of that stuff my entire life. Because then you're kind of teaching them alongside the kiddo. But it does require, a lot of education and a lot of the same things that you're doing with the kids are helpful for the adults too. So a lot of the times it's taking some space, regulating, modeling, specifically for neurodivergent adults and neurodivergent kids. I think modeling is one of the most important things that they can do. So showing youth how to exist in a world that doesn't necessarily support neurodivergent people. Yeah. And I remember too, like working with a lot of kids or teenagers, and they'd have that aha moment. And then the parents are like, well, I think that you're just kind of giving them an excuse because they're not doing what they're supposed to be doing.
There's also another question in chat that from Heather. What's your favorite response when teachers, adults don't see value in regulation practices?
Hmm. I I tend to I tend to be I'm not even sure if I have the best responses in those situations because I am pretty direct in advocating for my clients and their needs, um, and trying to explain neurodivergence and capacity. And I think that it is really tough because especially I'm thinking about this one particular meeting I attended at a school with a 16-year-old who had ADHD and a lot of trauma. It was June, and they were not able to do any of their work. Like they weren't able to complete any of their projects, but they were still going to school every day. But then they'd come home and they'd play video games for like 4 hours. So the school was having like disciplinary meetings day after, like week after week, being like, you need to do this work. And I know you can do it because you did it in September. And then the kid was even then being like, well, I'm lazy. I even heard the teacher say in the meeting, like, you're just being lazy. You're not trying hard enough. And I think that we live in a world where it's kind of the myth of meritocracy, where if you try hard enough, then you're able to get where everybody else is able to get. And that's not necessarily true. And sometimes the hard reality of working with folks who are neurodivergent in a system that doesn't support neurodivergence is that you have to work with teachers to understand that it's like, okay, well, if you're not able to provide this accommodation, then like we're teaching this kid that something is better than nothing. So like if they're able to get half of a paper done, that's better than getting none of the paper done. So in that setting, I was trying to explain that to the teachers, but they decided that that was not true. Again, I think that it's like multiple conversations that you have to have over and over again because our society really isn't catered towards neurodivergent folks. Um, I'm also thinking about other resources right now for adults who are neurodivergent. There's a lot of podcasts out there. Um, I'm specifically thinking about like Casey Davis, who is a licensed professional counselor. She did this struggle care podcast for a while. She doesn't do it anymore, but she has a lot. I think she has all of the episodes still. And she also talks a lot about parenting neurodivergent kids as a neurodivergent parent. So, along with the handouts, I'm going to provide you all with a resource list with some recommended resources. Um,
I
let's
think
see.
we have enough for one or two more questions. But Rachel has one in chat.
Sure.
She says, we work with a lot of kids who have been diagnosed with ODD and ADHD. Can you share any thoughts on productive ways to interact with these youth?
Yeah. Rachel, what kind of setting do you work in? Or well, like in
Hi
what
there.
capacity do you work with youth?
Hi
Sorry.
there. We work. I work for the Firefighters Burn Institute, and we work with youth who have the tendency to misuse fire. So we have a program, an academy to educate them on, not only fire but making good decisions and peer pressure and fire safety. And we notice when we have these children through the program and in the academy, um, I would say, I mean, well over 75% are diagnosed with ODD and ADHD at the same time. So it can pose challenges in the academy setting at times.
Mm-hmm. Yeah, that's a great point. That I'm actually thinking about a client I had who probably would have benefited from your program because he had just started setting fires and had a diagnosis of ADHD. And what I noticed at that point in time too, and also having the diagnosis of oppositional defiant disorder, if they have that concurrently, they've been told over and over again that they are a bad kid. And sometimes they lean into that. And so then they just are like, okay, well, I don't see any problem in doing this. And they just let the impulse control. They're like, well, if I want to set a fire, I'm going to go ahead and set a fire. And I know that it's not right, but I'm going to do it anyway. So a lot of that work, yeah, the self-fulfilling prophecy. That is like particularly tough for youth who have gotten to that point because oftentimes I find that behaviors like fire setting aren't necessarily just like, oh my gosh, everything was great. And then all of a sudden one day they did this. Could be, but generally I find that it's part of like a pattern of behaviors that took them to that point. So then it's not just teaching them the skills, but it's undoing all of the internalized bias that they already have towards themselves. So I don't know if that's super helpful, but I would say similar to the other interventions that we talked about, using those same interventions with these use. Yeah, fire setting is usually a symptom of something else going on. So it's really tough because it's a super dangerous behavior. And there's also generally a lot of trauma paired with the ADHD. It it is a perfect storm. And again, with the oppositional defiant disorder, even if a teacher sees a kid come in with an oppositional defiant disorder, they're probably already going to have like a little bit of a feeling or attitude towards like how that kid is going to present. And that will then influence the way that adults interact with the youth, which again, we talked about relational interactions and how youth who are neurodivergent are particularly sensitive to that. So showing up as an adult that is non-judgmental and supportive while also providing, and again, that's not this validating is not the same thing as in saying like that's okay. You can still provide the like, this is not okay and this is something that we need to work on. I understand maybe why you got to that point, but just showing up in a very non-judgmental, authentic way and trying to show them that adults are safe people who listen to them.
Thank you. No, that absolutely makes sense. Appreciate it.
Yeah, no problem.
So we are past the time, but I do want to just say a huge thank you to Shannon. Thank you so much for sharing your time and your expertise and all the insights you shared with us today. It was a very incredibly meaningful session. We learned a lot of different types of tools and just appreciate the knowledge you shared with us today. Before we officially close out, I do want to ask if anyone would be able to stick around just for a little bit to complete that brief evaluation form. Please note that the completion of the evaluation is a required order to receive your CEU credits with um, with any of that. Sorry, but no, please stick around, complete that form. We'll probably also email it to you as well in case you don't have the time to fill it out right now. But it will help us improve our future trainings, ensure any continued offering topics for anything that we can best support you guys on how to better help your clients. So it's been put into the chat. But other than that, if you have any further questions, feel free to stick around. If not, have a great rest of your day. And I think that is all. And I'll put the CVCA socials in the chat as well if you want to check our YouTube, our website, and our LinkedIn. That's anything else, Shannon, or
No, thank you so much, everybody, for being here and engaging. It's so much more helpful and practical, I think, when folks are able to apply their own experiences. So thank you for showing up and being wonderful participants. And please reach out if you have any questions in the future. You know, I'm always available and really passionate about this topic. So let me know.
yeah, and I'll put Shannon's contact in my follow-up email for you all if you have any additional questions for her. But